Okay, we're half past and we've got two really exciting things to hear about today. We'll do our normal standard work, which is to hear both report outs, and then we'll move on to some questions and answers at the end of the session. So I'm delighted. Have we got Shabana with us from Children's Phlebotomy?
Yes, I'm here.
Great to see you, Shabana. And this is your 90-day report out, isn't it? Oh, it's great to see
That's right, yeah.
all of the colleagues in the room over there as well. So brilliant. I'll hand over to you then.
Thank you. Good afternoon. My name is Shabana Jabbar and I'm a phlebotomy supervisor at the LGI. My role in this project was process owner. In September 2023, phlebotomy took part in a rapid process improvement workshop, which involved collaboration with staff from children's outpatients, play leaders, and our own phlebotomists. I'm here today to present the remeasures at 90 days. The aim of this project was to improve patient experience in children's phlebotomy because over the last few years, we have seen increased demand from children's outpatients, clinics, and GPs. This has led to long waiting times, mental and physical pressure on staff, and negative experiences and negative feedback from patients. Our sponsor, Claire Woodrow, set us the target of a lead time of 20 minutes, which was over half the original lead time of 52 minutes and 38 seconds. At the 60-day remeasures, I explained how we had continued one of the PDSA cycles we started during the RPIW to have one phlebotomist completing a clinic list with the assistance from staff in children's outpatients. The standard process is to have 2 phlebotomists with every child, which isn't always required as not all children require support from another phlebotomist. At the 90-day remeasures in December 2023, we continued this PDSA cycle, and it's been challenging to change the phlebotomist's mental value of the two phlebotomist rule. But we are starting to see them adapt to the changes now. After the 90 days, we've continued this PDSA cycle in children's outpatients and made it a permanent part of the phlebotomy service we provide. We've renamed it POP Clinic, which is an acronym of Paediatric Outpatients. The home team were involved in the renaming of this clinic, and we hope that it will empower our staff and increase staff morale to be part of such a significant moment in children's phlebotomy. We have also continued with the children's phlebotomy training to increase our workforce with a focus on skills such as communication and distraction. Following the success of POP Clinic, we have changed the standard process in children's phlebotomy to have 1 phlebotomist with every patient. This means that there should always be 2 phlebotomists taking blood in children's phlebotomy. At the 90-day remeasures, our lead time in POP Clinic remained at 10 minutes and even dropped to 8 minutes after 90 days. It shows that POP Clinic is working well, and we have received high levels of positive feedback from patients and staff. In addition, the phlebotomists that were reluctant to work in the clinic before are now volunteering to be assigned there. The lead time in the standard process in children's phlebotomy has also reduced from 52 minutes and 38 seconds to 24 minutes and 15 seconds at 90 days and 29 minutes and 12 seconds after 90 days. We've almost achieved the sponsor challenge with this lead time, which is a great improvement. We expect that with more time and with the changes implemented recently, we will match the sponsor challenge. The working process, the WIP, which was the number of patients waiting in the process at one time and includes the patient in the phlebotomy room, has regularly remained at 5 patients at 60 days, 90 days, and after 90 days. This shows that the number of patients waiting at a single point in time is consistent over time. We chose to measure the WIP at the busiest time of the day to capture when we had the most patients in the process. We found that the number of patients leaving without having a blood test has slowly reduced over time from 4% at 90 days to 1% after 90 days. In context, the 1% of patients that left means that 5 patients left without having a blood test since the last week of December 2023. This number is more significant when you remember that in September 2023, there were 19 patients that left on one day. Finally, we've received a drop in negative patient feedback at 36% and a rise in positive patient feedback. We've received this feedback from patients in both POP Clinic and in the standard process in children's phlebotomy. Please take your time to read the feedback from patients. It's been empowering for the phlebotomists to hear such compliments and to realise that their hard work has been recognised. At the 60-day remeasures, I mentioned how it had been challenging to improve staff morale within the department. At the 90-day remeasures and after 90 days, we found that receiving positive patient feedback like this in our weekly huddle has been valuable in improving the staff morale. In general, though staff are still concerned about working alone, the phlebotomy management team have tried to be as supportive as we can by leading by example. We've worked in children's phlebotomy with the new process, and we found that showing that the process works means that the staff are more willing to adapt to the change. Overall, I found that throughout this project, there have been some challenges, but perseverance and encouragement from my management team and the KPO team has helped keep the momentum with these improvements. Finally, I just want to thank everyone that has been part of this project. Catherine has been amazing with helping translate the data. Rachel, Jimmy, and all the KPO team, Dylan, my line manager, and Claire, our sponsor and matron, have been so supportive and positive even when I've been having doubts. Thank you also to Sandra, Kirsty, and all the staff in children's outpatients for being so supportive to the whole phlebotomy team and allowing us to test this PDSA cycle in your department. I look forward to working with you all on the next project. Thank you for your time.
Absolutely brilliant. Magnus, I'll bring you in for questions at the end in our standard work, if that's okay, after we've heard from Sim. I'm ever so sorry. But, I can see we're all itching to just, that was just so clear as well, so well presented, and some brilliant work. But we'll come back to it. Great to see some work going on around HCAIs in SIM. I've not got a name on the agenda, so who from SIM today is reporting out?
I'm not actually on camera, Jenny, it's Jimmy from the KPO team. So hello everyone, my name's Jimmy, I work for KPO and I'm the workshop lead for this RPIW, focused on healthcare associated infections and how we can make improvements to this process. So this is our project form which frames our work for the week as standard. So this process in particular, we identified significant waste associated with the burden of work for staff trying to investigate these infections, as well as challenges with the learning that we were able to take forward from them. Ultimately, this means that we're missing opportunities to improve the care we provide for our patients and reduce the prevalence. So this team is all key parts of the process. We've put them together in the workshop to see what we could do.
Thanks, Jimmy. Hello, my name is Katie. I'm a KPO specialist and I'm the team lead for this week. You can see on screen the target progress report. So that's got our baseline data on it. We began by measuring the median number of HCAIs across the 6 wards that were in scope of this, 6 older adult wards within SIM, which was a median of 8. We had a really big lead time of around 99 days, which obviously there was a lot of opportunity for improvement there. There was a quality and morale metric that focused around the questions to staff. So have we got the right people within the process, and is the burden of work fairly shared? We've also got a quality metric there of what percentage of time was being spent on sharing the learning, because that was identified as a really important part that felt that wasn't being focused on, and that was at 25% of the baseline. And then we wanted to 5S some of the investigation documents, so that was started at a level 1. On the next slide, we can see the standard worksheet, and you can see it speaks for itself. Lots of information flow there moving around. And then we've got the value stream map, so that shows us our process steps. But more key that we wanted to get out of this on this slide is around what was value added. And there was about an hour and a half out of that entire 99 days we felt was value added, and a lot of waiting and waste in the process.
Hello, my name is Sharon Morrison. I'm a Patient Safety and Quality Manager, and I'm one of the team members for this event. One of the objectives was to align our HCAI process with the Patient Safety Incident Review Framework, PSIRF. PSIRF requires us to engage compassionately with those affected by patient safety incidents, and with agreement involve them in our review. On screen, you can see a process flowchart completed for our current RCA process. It demonstrates an industry focused on completing and checking forms, taking staff away from the patient. The median time to completion, as Katie said, was 99 days. With our proposed model, our learning review commences when the infection is identified. It's patient attentive, ensuring that the patient and family are informed and that their observations, opinions and concerns are heard and included in our review. Previously, we would share the findings on completion of the RCA process, so 3 months later. With the change in focus, we can let patients and families know what we've learned and what we've done about it when it's meaningful.
Thank you, Sharon. My name's Jessica Martin. I'm the medical lead for IPC in the Trust, and I've been a team member as part of this workshop. And I'm really excited to share with you a new concept for the Trust about how we investigate infections when they've happened in our care. So this is the case huddle. This is moving our investigation of infection from offices, emails and administrative tasks into the ward area itself. So what will it look like? At the point that our team and microbiology and infectious diseases team contact the ward about a new infection, we will be asking the team to do a case review at the time on that day. And this means that the people who know that patient best and the experts in that area will be trying to understand the days and steps that led to that infection, rather than it be something that's done weeks or months later, as in the current model. The ambition for the case huddle is that the information we're asking for will be at the fingertips of those staff members, and they will not be having to leave the ward to go and find further information that they will know as part of the routine care they're providing. There's 3 key elements to the case huddle. The first is the team. So this will be a joint-led process between medical staff and nursing staff on the ward. And it's been really lovely to see that in action as we've trialled this huddle process. We will also be able to bring other team members that are important to that case, which may be pharmacy colleagues, clinical support workers or other specialties, to try and understand what's happened. This joint model will actually run through our whole process of a joint and equal medical and nursing leadership of infection review. The most important member of the team on the huddle will be the patient, of course, so that we can understand how we deliver a compassionate response and investigation to the infection that they've experienced. The second aspect after team is timing. So this will be quick. So the information that we have should be more accurate than the current method. And it also means that if we identify improvements in the care that we want to provide, we can action them at the time in the right place for the patient. And the learning will be linked to that patient, so that as staff remember how to offer best practice, the memory of how and when they learn that will also come with the memory of the patient that they cared for. And from an IPC leadership point of view, the information that we generate through this real-time review will be collated and lifted up through the organisation to look for new learning. And the benefit for us will that it will be based on the expertise of the people looking after the patient at the time. So this is a revised standard worksheet with a much shorter process, fewer steps to get the information from the ward to the IPC team. And that implementing this patient safety model as a case huddle will allow rapid action, but it will also allow a deep understanding of events provided by the experts at the time, which will lead to a systems-based approach so that we can develop improvement actions for the Trust as a whole.
Thank you, Jessica. Hello, my name is Charlie. I'm one of the matrons in infection prevention and one of the process owners for this event. So the immediate recognition during this week is that with the evolving landscape of infection, the RCA process can no longer answer our questions to either meet the needs of the patient or the organisation in terms of sharing learning. So the current RCA process will cease to ensure the right people are involved at the right time and the patient remains central. And as Sharon and Jessica have commented, the process map identified that there were multiple unnecessary steps with non-value added waste. In addition, the percentage load chart showed that the workload was unfairly distributed in our current process, with the ward manager spending 545 minutes completing an RCA case. The staff questionnaire identified in terms of morale and quality that 31 out of 33 people had a negative response when asked about looking at the distribution of work, and 15 out of 30 staff felt that the right people were not involved in the RCA process.
Hello, my name is Sue. I'm ward manager of J17 in SIM, and I'm a home member of this event. So we applied 5S to review the process whilst the same time ensuring our statutory requirements were met and to help us identify where would be the most impact. Using the ideas we produced at the beginning of the week, we have developed a new process. As a team, we have taken the new process to the Gemba to test our ideas in keeping the patient safe. We have spoken to medical and nursing staff. We took the same morale and quality metric, and this time, out of the 8 people asked, only 1 had a negative response to both the people involved and the distribution of work metrics.
Thanks. And our distribution of workload is now more evenly spread and gets the right people involved from the very start. The percentage load chart for the band 7 now shows a cycle time of 175 minutes, a reduction of 68%.
Hello, my name is Fiona Simons and I'm the lead nurse for clinical quality in SIM CSU. Part of my job role involves looking at HCIs and what we can do to prevent these. I have been a team member in this project. Our current model of Investigate HCIs focuses on taking actions locally and sharing learning at multiple forums where we focus mainly about the things that we've got wrong. Not only is this process repetitive at times, but speaking to junior staff in our Gemba walks, it demonstrated that learning isn't reaching all staff, especially junior members. Our new process will shift from sharing learning to taking action in a way that will have a greater impact through meaningful change. Actions will be approached at a CSU-wide level instead of multiple individuals trying to take action on the same thing. Quality time will be spent on generating ideas to resolve the issues identified and creating impactful solutions. This will include a change to our current CSU IPC meeting, becoming a multidisciplinary forum where responsive actions are generated. Further work will be needed in looking at how those that need to know about our actions hear about them. There will be a direct link back to the initial prevention work and involving the patient at the outset.
Thanks, Fiona. Hello, my name is Brad. I'm a matron in SIM and a process owner for this new model of working we've proposed. The new model ensures that the right people are in the right place at the right time to investigate healthcare-associated infections. A new MDT-led approach to investigations where immediate actions are not only formulated but actioned in the moment with and by the teams they are relevant to brings to the forefront of our clinical practice the impact that our care has had and will have on current and future patients. Working through and creating this new model highlighted the need for a change in ways of thinking to move us to a proactive approach to all infections, moving away from the current reactive process to only healthcare associated infections. The new process should very much be seen as a cycle of not only continuous feedback of learning, but feedback of the impact and results of actions that have been taken, showing the impact that has been had on the teams involved, but more importantly, the patient. The next stage is for us to test in practice this new model with an ambition to share our new standard of working within and then across SIM and ambitiously pass the model across the organisation to share and implement across other CSUs. We have identified waste in the duty of candour process and we will look at our templates and policies to support staff to get the second duty of candour letter right first time and reduce the time needed for review and revision. We have also identified a new need for further training and development for those going to be involved in the review process. Over the next 30 days, there is work to be done to empower teams to engage with the new model, collect further data to demonstrate the benefits and reduction in waste, and determine how well the new model has been received by people using it to feed back into our morale metrics and overall targets.
So just back to the target progress report to show our final measures for the week. There were a couple that we were unable to remeasure due to its long-term sustainability that we'd be looking at, so that wasn't possible to show that today, but the ones that we can see there that are in green are the ones that we've remeasured, so some really positive results. The lead time, which is from the notification of the HCAI to the learning being shared and actioned, is now 15 days from 99, so that's a 84% change. The two quality metrics Sue's already spoken about, but those the quality and morale metrics around the staff feedback on that from the home team have changed significantly, as you can see there, as Sue spoke to. And the final one is the quality metric around how much of the process is currently learning. So we have increased that slightly, but we think because of the duty of candour part that Brad's just talked about, that's affecting our lead time there at the moment. So potentially not helping us with that and seeing that change so far.
Thank you, Katie. Hello, my name's Tony. I'm a patient partner with the Trust and I've been an away team member for this event. This week has not been about adjustment in order to survive. It has engaged in struggle for transformation. Central has been the need to align and harmonise quality assurance and quality improvement. When these two dance together, they promote an immediate reflectivity which creates incremental learning in real time. They interact and support each other. Embedded, this empowers shared learning, identifying what should be done to create value, and does it. This has implications beyond SIM to the CSU, across the organisation, and to healthcare as a whole.
So a huge amount of learning this week, as you'd imagine, taking on such a significant project, really, beyond what we normally do. So credit to the teams involved. I think one of the key realisations, and Tony framed this out in the week for us, that you should realise that quality assurance and quality improvement are two sides of the same coin. Sometimes they're held in tension, but actually they work best when they're synchronised. The theme coming through from the team, I hope you've heard, is that if you put the right people in the right place at the right time, you can really drive value, and that's value from the perspective of the patient, which is always where we should come at it from. And a really nice quote shared by our colleagues from Virginia Mason, who've been with us this week, from Victor Hugo: "There's nothing more powerful than an idea whose time has come." I think we could all acknowledge that, as Charlie set out with her statement, this process wasn't really working for anyone, most importantly our patients. And we didn't have to persuade many people that it was time for something to be different. So just to conclude with some thank yous. Thank you to Stuart and Gillian, who sponsored this piece of work with their encouragement, optimism, and giving us the license to have a blank page for this, which we really needed. Team members who couldn't be at Report Out but have been influential, instrumental almost. Ali, Lam, Jill, Dan, thank you ever so much. Whole team who you've heard reference to, tested our ideas, checked them out, given us some feedback, and also hiding behind my name on the call, Amanda and Amy from BMI, who have been doing some assessment and feedback with us this week. Thank you for your contribution and being the best doorkeepers that we could have asked for this week. I've missed off someone and I'd like to call it out. Mike and the pathology team, those who've supported. You can't quite see how good this room is behind us, but I can assure you that the new labs for pathology medicine are amazing. So thanks for the team that allowed us to be here. I'm sure you'll be delighted when you can move in and we have to move out today. So that's our report out. Thanks for listening.
Oh my word. Oh my word. I don't know what to say. Wow. So I'm going to open it up for questions, but I did just want to say, did you say Amanda and Amy are over from VMI? Yeah, great to see you both. Welcome to the UK. Sorry it's as cold as it is, but thank you for supporting what sounds as if it has been an absolutely incredible week. So let me open it up. 2 brilliant report outs. Let me open it up for some questions. Comments, feedback. I'm sure the team would love to hear your thoughts. So Ravina and then Magnus.
Thanks, teams. I was lucky enough to actually go to the workshop for the infection prevention control thing that we've just heard. And I just wanted to say, it really brings it home, doesn't it, that actually everybody does the right thing for the right reasons. And when something's not working, we just add something else. And what these diagrams have shown us that actually over the years, we've got all these complex processes in place that make it so confusing for everyone. And what you've brilliantly shown here is that actually stripping all of that out by having some time out, that gives you clarity and brings a team together just to think things through and work together and collaborate. You end up with a process that's so much more slicker and really, really clear, so that all our teams at the front line from at every level will understand it and actually will bring about the improvements that you've identified. So this is fantastic, and I can see this being rolled out across the whole organisation and then also looking at other areas as well. So well done. Thank you.
Brilliant. Thanks, Ravina. Magnus?
Clearly not well versed in standard work. I wanted to get in really early, Shabana. Just say tip top presentation, great work, and I was just really buoyed by the patient focus that you brought to it. I love the patient statements at the end, so really well done. And then Team Sim, I can see Liz is coming in after me. I absolutely echo everything Ravina said, and what a fine way to spend a Friday lunchtime. Thank you all.
Brilliant. Thanks, Magnus. Liz, great to see you.
Thank you, Jenny. Well, I'm so pleased with the work. Well, it was so great to hear the work from paediatrics, but the work that the team in SIM and KPI have been doing in terms of healthcare associated infection is so important for us, where HCAIs are so prevalent, unfortunately, in our CSU. But it's absolutely fantastic to see that the result of this is to what we've felt for some time is that the process has got in the way of the actual doing, and what they've evidenced and been able to strip out is bring the priorities back forward so that it's patient-centred, but also the learning for our teams. And not only is this going to save a whole lot of time and reduce waste, but also I think it's going to enhance our ability to respond to the real serious challenges that we face day in, day out. So I'm so grateful for everyone's participation and support with this, so thank you very much.
Brilliant. Really, really echo everything that everybody is saying. So James and then Karen.
Yeah, two brilliant presentation, guys. Thank you. I was really struck in the HCAI RPIW that nearly 10 hours of ward manager time is spent on each RCA. That just feels absolutely crackers. So moving to this much more timely, much more reflective, conversational, collaborative approach feels really, really promising. And I thought Tony's reflections on the relationship between quality improvement and quality assurance were also really, really insightful. I suppose my question is, as you start to, as you said, you start with your first PDSA, how are you going to interact with your wider home team and disseminate this work so that you can generate that spread effect through the CSU and then out into the wider trust?
Sim, who wants to pick that one up?
I've been given a nudge on that one. As you can imagine, it has been a conversation both in the planning and the delivery of this event. Credit to the team for getting as far as they have with what is a big bit of work. It will need support going forward. So we've got the right people to test it in our sample wards. There's 6 wards in elderly people's medicine. So one at a time, one person at a time in the beginning, but then we will be looking to build potentially a sponsor team around this so that we can really maximise the benefit that it offers for the organisation as a whole. So yeah, watch this space because we're looking to recruit some people to help us with getting this far and wide, which is where it needs to be.
Brilliant, brilliant. And a really clear plan, again, using the improvement method. So well done, Jimmy. That sounds brilliant. Karen?
Yeah, so again, really great presentations from both. I think the SIM ones made me reflect on going back and looking at some of our processes and seeing what we can take out of those steps. But I have to say, Shabana, what a fantastic presentation, and that real patient focus I know has been there at the heart of everything that you have done. What I'd like to just point out is that we're now starting to see many more compliments about the service from patients, and also the patients and the families being able to name the phlebotomist, which for me was a real frustration before. Then we are seeing negative comments. So really positive, really fantastic. I know it's been tough and I know that you've stuck with it all the way through, but be really proud of yourself. And it's onwards and upwards next, as you would expect. We're on to our next ones, but well done, all of you.
Karen, I completely agree. Shabana, that was the piece that stood out for me. I wanted to ask you how you helped your colleagues sort of build their confidence around the 2-person role, but you answered it, which was to put the patient at the centre of the thinking. So I just thought it was absolutely phenomenal. So let me bring Team Sim in.
Thanks. Sorry, I just felt compelled to comment on Shabana's work as well. Because my focus, obviously, imagine, is this work this week, but I couldn't have asked for a better setup for our report out. You know, everyone here was going, yeah, that. So if you wanted something that motivated a team to keep going 30, 60, 90, you've heard it from Shabana, because that was hard stuff. You know, it was paused. There was a lot of personal investments and challenge in there. So it's a huge well done. I was absolutely beaming seeing what you reported back, because I kind of know how hard you'll have had to work to get it there. So if we needed any kind of incentive, that's it, because it's brilliant. So well done.
Wow. Well, I echo Magnus's point. What a way to spend a Friday lunchtime. That's got to have been one of the highlights of the week for me, without a doubt. Huge work, all putting the patients at the heart of everything we do. One of them focused, well, both actually focused on our 7 commitments. I just, yeah, amazing, absolutely amazing. So if you are working this weekend, I hope it's a happy and a safe shift. And if you're not, then I hope you get some well-earned downtime. Brilliant, brilliant work. Well done. End of report out. Nice to see you all, folks.